My name is Carl Chudnovsky, and I chair the Test Administration Committee for the American Board of Emergency Medicine. Today, I would like to give you information about the structured interview and what to expect. The structured interview is similar to what you will recognize as a typical faculty interaction when presenting a case. It should be conducted utilizing standard medical terminology. The structured interview case allows ABEM to test reasoning and other skills that are difficult to test using multiple choice questions or traditional oral cases. The intent is to go beyond whether or not you perform a specific action, but rather to understand why you did or did not do something. The structured interview is a highly scripted series of questions that the examiner will use to lead you through the case. It is a stimulus response format in that you will be asked to respond to specific questions asked by the examiner based on information given at certain points in the case. There is no role playing, but you may be asked to clarify your answers. Be as specific as possible. It does not include a dynamic history and physical. Rather, you will be asked to give a comprehensive list of the information you need to move to the next step. In the interest of timing, you may be interrupted by the examiner to move you through the case. This is not a reflection of your performance. You may or may not see information you requested, or you may be given information you did not request. This means that every candidate receives the same information as they work through the case. Take what you have been given and move on. You may be asked questions about treatments and other actions you would do in the emergency department. Please be as specific as possible. Later in the exam, you may be asked additional questions regarding disposition. This is a structured interview case. There is no role playing. In response to the questions I will ask, please give me a list of information you would gather to come to a final diagnosis. At times, I may interrupt you to move you through the case. This is not a reflection of your performance. You will have 15 minutes to complete the case. Before we begin, do you have any questions?
No, I don't.
Okay, then. The patient we will be discussing is a 42-year-old man with epigastric pain and vomiting for the past 6 hours. Here's the initial information. After you have read it, please give me a list of the additional historical information you would want to ask.
Okay, I would want to ask the patient a complete pain history. So I would want to know about what makes the pain better, what makes the pain worse. Has he tried anything for pain relief at home? The quality of the pain is sharp, so I'd ask him to define that a little bit better for me. Does that mean severe, or does that mean stabbing pain? I'd want to know if the pain's always been that way. I'd want to know the onset of the pain, whether it was sudden or kind of gradual. I would want to know the symptoms associated with it. I see that he's had some vomiting, but has he had fevers, constipation, diarrhea, any other symptoms associated with it, including chest pain or leg pain. I would want to know the temporal relationship of the pain. Did anything happen either yesterday before the pain occurred or within the last week? He hasn't had any recent trauma, anything like that. I would want to know, I see that he has no history of GI disease, no past surgery, no comorbid medical conditions, but I'd want to ask specifically, has he ever been admitted to the hospital overnight? Does he take any medication on a regular basis? I would want to know his social history, and I would want to know his occupational history as well.
All right, thank you, doctor. You asked about his social history. What specifically would you want to know?
Oh, I would want to know if he's a smoker. I would want to know about substance use issues, both prescription drugs and recreational. I would want to know about alcohol use, which includes daily alcohol use, a weekly estimation, and if he's ever been diagnosed with an alcohol use disorder in the past.
All right, thank you. You asked about alcohol use. Why is that important to you?
I think that alcohol can precipitate a lot of GI disturbances. So kind of getting a concept of if he's a regular drinker, if this could be acute alcohol intoxication, I think that those would be important.
All right, thank you. The pain radiates to his back. He drinks alcohol infrequently, but drank heavily for him last evening. He had 6 beers and 2 shots of tequila. He has no known history of gallbladder disease. There has been no blood in his emesis nor melena. Doctor, based on what you now know, please list the specific physical examination findings you would be looking for.
I think I would do a head-to-toe physical exam, starting with AGENT, specifically looking in the mouth for any signs of that he may have had hematemesis, trying to gauge his fluid status, and also looking for any evidence of pallor. I would do a heart and lung exam. I would do an abdominal exam, including a rectal exam. I would do a GU exam, and I would do specifically a vascular exam and checking lower extremity pulses, looking for lower extremity edema, and making sure that he didn't have any palpable pulsatile abdominal masses.
All right, thank you, doctor. You mentioned that you would do an abdominal exam. Can you be more specific with what specifically you would be looking for?
Oh, yeah, sure. Sorry. First of all, I would look at the abdomen, then I would listen to the abdomen, and I would palpate the abdomen, and I would just make sure that there was no evidence of like dullness to percussion, like that he has ascites, anything like that.
All right, thank you. Why is auscultating the abdomen important?
I think that there are a number of abdominal conditions that can have abnormal auscultation findings in the abdomen. Like if he, for some reason, has a bowel obstruction, I would anticipate high-pitched bowel sounds. If this is an ileus or if it's related to an adverse drug reaction, he may have absent bowel sounds.
All right, thank you. The patient is slightly diaphoretic and appears to be uncomfortable and nauseous. Oral mucosa is dry. There is moderate epigastric tenderness without rebound. Bowel sounds are normal. Stool is negative for occult blood, and the vascular exam is normal. Doctor, based on what you now know, what are the top 3 items on your differential diagnosis based on the most likely conditions?
Peptic ulcer disease, gastritis, gallbladder disease like acute cholecystitis, and pancreatitis.
All right, doctor, you gave me 4 entities in your differential diagnosis. Can you please give me your top 3?
Sure. Pancreatitis, peptic ulcer disease, and cholecystitis.
Thank you. Doctor, based on what you now know and the working differential diagnosis that you just provided me, what, if any, diagnostic studies would you order?
I'd like to get a basic metabolic profile and a CBC. I'd like to get liver function studies, including transaminases and bilirubin. I'd like to get a lipase and an alk phos, which is part of the LFTs. I'd like to get coags. I'd like to get a urinalysis. And I'd like to do a CT of the abdomen. Can I have just a minute to think about those?
Sure.
Yes, that's what I'd like.
All right, thank you. You indicated that you would order a CT of the abdomen. How is that helpful to you?
I think that since cholecystitis is one of the tops of my differential, I would like to see if there's any evidence of gallstones. Although a right upper quadrant ultrasound can show me that as well, I think that my differential is broad enough at this point that a CT will give me more information than the ultrasound would.
All right, doctor, thank you very much. Here are the results of some studies on this patient.
A little bit of a white count. Seems low. Lipase is elevated. Okay. Peripancreatic fast trending. Okay.
All right, doctor, based on what you now know, what treatments, if any, would you order, and or what actions, if any, would you perform in the emergency department?
Well, I'd start an IV and give him some IV fluid. He looks a little bit volume contracted. His lactate's elevated and he's got a bicarb of 17. I would give IV analgesia. I would replace his potassium, and I would reassess him after initial treatment, specifically reassessing his pain.
All right, doctor, thank you. You mentioned that you would start IV fluids. Why would you do that?
Yeah, so looking at he's got a little bit of a lactic acidosis and his bicarb is 17. And I believe his mucous membranes were a little bit on the dry side. So I think he's going to need, I think he's volume depleted somewhat, and he'll need some IV fluids for resuscitation. And also his lipase looks like it's elevated. So I'm going to be keeping him MPO. So at least need to keep maintenance fluids going, if not resuscitative fluids.
All right, thank you, doctor. Based on everything you now know about this case, what is your final diagnosis?
I think that it's acute pancreatitis, and it looks like primary pancreatitis as opposed to associated with a gallstone.
All right, doctor, thank you. Based on what you know now, what should the disposition of this patient be?
I would admit him to the hospital, and I would keep him NPO.
All right, doctor, thank you. You indicated that you would admit this patient to the hospital. Why would you do that?
I'm only looking at him in one point in time, and I realize that pancreatitis can progress fairly rapidly and can become a severe illness. So I would want to keep an eye on him, do serial exams, and make sure that his clinical situation doesn't worsen.
All right, doctor, thank you. At the time of admission, what specific actions would you take?
Well, I would explain the disposition to the patient. I would talk to the admitting physician and tell the admitting physician that the basic demographics of the patient, and that he's just been diagnosed with acute pancreatitis, that he's stable. I'd tell the admitting physician what his response to therapy has been in the emergency department, and give him a current set of vital signs and how the patient is doing right now.
All right, doctor, thank you very much. This concludes the case, and I would ask if you would please tear up your notes.